So now we're moving on to another joint, the humeroradial joint, or the HR joint. This is going to be on the lateral side of the elbow. And in particular, we're going to start talking about the radial head to begin with. So you can see the radial head is positioned right here. There is a concavity to this portion of the radial head, which is where it's going to meet right over here. It's going to meet the humerus. It's going to articulate with this articular cartilage end called the capitulum. So at this portion, it is concave for the radius, moving on a convex humerus. However, we talk about this portion of the radius. We'll do that in the next series, how the radius is going to articulate with the ulna. And so now you have a convex radial head articulating on a concave ulna. So just make sure to separate those apart. In terms of what keeps the radial head secure, well, you can see right over here, you have this ligament, the annular ligament. It's sort of like a C shaped around the radial head to keep that pinned down into the ulna. So it's going transversely around to keep that nice and secure. In terms of the cap, what caps the radial head? So the way I always learned it in school is that the capitulum caps the radial head, or you can say the capitulum is on the top or superior portion or proximal portion to the radial head. And there you go. Now, besides the annular ligament, there is another ligament that's going to also help to secure the radius in place. But this time, we're going to talk about the frontal plane. Or if you think frontal plane, we're probably thinking abduction, so going this way or going this way. But in particular, to keep the radius going in those directions, we're talking about a varus or a valgus force. So which ligament is basically connecting from there to there? Yes, so that is the LCL, or sometimes refer to this as the radiocollateral ligament in that area. So with this, which two types of forces does it restrict? So it's going to basically stop the radius from going in this direction. So it's gonna block that. So what kind of force would that be? That'd be a varus force, the opposite of a valgus force. And also, because it's connecting the humerus to the radius, so if the radius wants to go in this direction or in this direction, that LCL, or radiocollateral ligament, is going to basically block it. It's going to restrict either a distraction of the radius, or you could say a distraction of the radial head away from the capitulum. It's also going to prevent a varus motion. For that reason, is it commonly injured? Do we typically get a lot of forces into that varus position? We typically don't. And if you think about a lot of the throwing or other forces, it provides a lot of distraction force, but it can be injured just like any ligament, but typically it's not as injured as the MCL would be. And then just to clarify some of the anatomy, this is the LCL, so this is the LCL that you have pictured there, and this also is another portion of the LCL. So the LCL really has two bands to it. There is a radial band and an ulnar band, but because we typically call this the radiocollateral ligament, it does contain both lateral bands, but they call it ulnar and radial. So it is a little confusing. So just be aware that it does have two bands, an ulnar component, but it's not the same as the ulnar collateral ligament. That's just how they named it. Oh, what's going on here? I was going to talk about the annular ligament, but a cheesy joke just popped up on my screen. That's weird. So why didn't the vampire attack Taylor Swift? Because she had bad blood. Yeah, so there you go. Sorry about that. Fun fact, I went to a Taylor Swift concert a few years ago, and I loved it. Okay, so let me get this out of here. All right, Taylor's gone, so we're back. So let me get my pointer on here. So with this annular ligament, you could see the radial head has been removed, and look at this annular ligament. You see it's basically this ring. So it is circular, or kind of like a C-shaped in this example, but it is circular or C-shaped. Where else do we have an annular ligament? Where do we have this annular ring or annular ligament? And I'll give you a clue. We have a bunch of them in the body. A lot of different annular rings within the body. Yes, so they are in the spine. So we have a lot of them within our spines. We have the annulus fibrosus, which encapsulates the center portion of the disc, the nucleus pulposus. So the annulus fibrosus is higher in collagen, higher in type 1 collagen, lower in water content. So it's a relatively thick, fibrous structure that can restrict movement and other play. Now let's talk about distraction forces a little bit here. Let's say you're picking something up, a kettlebell, a suitcase, a briefcase, something like that, that has some weight. Obviously, that force is going to be taken down towards the center of the earth, and that's going to pull as distraction force. It's going to create the opposite of a joint approximation. It's going to create a joint separation. You're going to definitely get that at the radiocarpal joints, but the radiocarpal joints are going to pull distally on the radius and the ulna, and also on the musculatures. But what you're looking at here is it does cause a change to this membrane here, this interosseous membrane. It actually tends to slacken that. However, with the oblique cord connecting the ulna and through the radius and the annular ligament, that's going to be lengthened there. So there's going to be a tautness or tension applied to that, a tensile load applied to that, just like there's a tensile load applied to the brachioradialis, along with a tensile load applied to the annular ligament. So as adults, usually our annular ligaments and other structures can keep the radial head in place. But in particular, what happens with children if they were to receive a sudden distraction load, taking their whole body weight and putting it through their upper extremities, where their collagen is still relatively weakened and it's more elastic in this nature as opposed to fibrotic? What can happen? What could dislocate? Well, you could get a radial head dislocation, where the radial head separates away from the capitulum or the humerus. This typically happens between 1 and 4 years of age, with a peak around 2 to 3 years of age. And we know that this would be prevented by the annular ligament and to some degree the oblique cord, but primarily the annular ligament. But also the LCL ligament would prevent this additionally. This does tend to happen more in girls than boys, but like anything, it can depend on the situation. All right, so we said it is more common to occur in girls, and typically it is also more common to occur on the left side. And if you think about that, well, why would it be more common in the left side? Well, a lot of parents or grandparents are right-handed, and they like to hold the hand on their right side. So their right hand, which would be the child's left hand. And so if this child suddenly runs away, or the parent or grandparent yanks quickly at the child's arm, it may dislocate there. Another thing that can happen is, let's say you have a child walking a dog. This is why you shouldn't really let a 3 or 4 year old walk a dog. Let's say you got a big dog that likes to run away. We'll just say the dog's name is Mamba. Mamba runs off and pulls with a rapid distraction force on the leash, and that could dislocate the radius from the humerus. So there's another mechanism for you. So let's talk about the opposite of distraction, which would be compression or approximation of the joint. If there's a force coming through the hand, such as when you're doing a push-up or you're pushing a cart or car or anything like that, or you're falling on an outstretched hand, a foosh, there's going to be a rapid loading or compression going through the HR joint. Now, what can happen with that? Well, certainly you can imagine it's not going to dislocate. That's not going to cause tension on the annular ligament and cause the radial head to dislocate. But instead, if this is done one time very aggressively or multiple times, it can result in an avascular necrosis, which is basically a disruption of the blood supply to the capitulum. And that impeded blood supply can cause necrosis or tissue death of the capitulum. So if there is pain in this area and there was repetitive, prolonged compression of the joint structure, it is important to make sure that the patient gets an X-ray to rule out any kind of necrosis that may have occurred at the joint. And that is the end of this one. See you in the next one.